The oral abstract session of the gastroesophageal results that were presented at ASCO this year included two abstracts that looked at how we could incorporate targeting of HER2 in the definitive treatment of locally advanced HER2-positive gastroesophageal cancer. Two trials. The first was the NRG trial, RTOG 1010, which looked at trastuzumab with trimodality therapy for esophageal adenocarcinoma with HER2 overexpression. And the other came from the AIO group in Germany, perioperative trastuzumab and pertuzumab in combination with FLOT versus FLOT alone for HER2-positive resectable esophagogastric adenocarcinoma. And this trial was called the Petrarca Trial. So HER2 has obviously been an extremely valuable target in human cancer. I mean, transformative for breast cancer when targeting for HER2 came along for HER2-positive breast cancer. And HER2 is also expressed in about 15% of gastric and about 25% of esophageal adenocarcinomas. The expression's a little bit different. First of all, arises in a different genomic context. Second of all, there's greater heterogeneity of expression. And we know that some of the HER2 dimerization partners, EGFR, HER3, and HER4, can also be expressed in gastroesophageal cancer. And we know from the TOGA trial that when trastuzumab is added to platinum-based chemotherapy for patients with metastatic recurrent disease, this enhances survival. So it's been of interest whether or not you could translate that to an earlier line of therapy. And the RTOG took a group of patients who were suitable for trimodality therapy, that is to say preoperative chemoradiation followed by resection. At the time this trial was mounted, I think that was the clear standard of care for these patients. And they selected patients who had HER2-positive disease and were not T4. So T1, N1 to N2, or T2 to T3 and any. And they stratified on adenopathy. So patients with low volume celiac adenopathy were allowed into the trial. And then they were randomized to receive a cross-like regimen. So radiation to 50 gray, paclitaxel and carboplatin, followed 5 to 8 weeks later by surgery, or the same thing with trastuzumab, followed by maintenance trastuzumab. The study estimated a median DFS of 15 months and had a very ambitious statistical design looking for a target hazard ratio of 0.6 for the addition of trastuzumab. And to have 90% statistical power in that analysis, they would have needed 197 patients with 162 disease-free survival events. So they fully accrued the trial, but the disease-free survival events actually were slower than they anticipated. This was not driven by delinquent data. And so they ultimately released the data with 135% disease-free survival events and 84% statistical power. And what they found was that there was no benefit for the addition of trastuzumab, and really none of the endpoints that you might look at to find evidence that maybe there was a little bit of benefit were all negative. So the number of patients who came to surgery was 81% with chemoradiation, 84% with chemoradiation plus trastuzumab. The number of patients who had a path-CR was 29% with chemoradiation and 27% with chemoradiation plus trastuzumab. The median disease-free survival was 14.2 months with chemoradiation and 19.6 months with chemoradiation plus trastuzumab. But that was a transient benefit, and the curves came together before the 3-year mark, and the hazard ratio for DFS comparison was 0.97. Looking also at median overall survival, this was 38.9 months with chemoradiation and 38.5 months with chemoradiation plus trastuzumab, and the hazard ratio there was 1.01. So this is a flat-out negative trial. It did have a little bit less power than anticipated, but looking at these results, you can't imagine to yourself that if there had been another 50 progression events, things really would have been much different. The median survival that they reported, just under 39 months, is actually not all that different from the adenocarcinoma cohort in CROSS, which also excluded T4 cancers at 43 months, and not quite as good as what was seen for the GE junction cohort in the FLOT perioperative chemotherapy trial. The investigators pointed out that there are possible sources of resistance in mutation in signaling molecules that are downstream from HER2, and they plan to do analysis for key signaling molecules like RAS, PIK3CA, and PTEN. They're going to look at HER2 heterogeneity. But my feeling was that this was so negative a trial that you have to imagine that there's adaptive resistance to trastuzumab that's developing as patients are being treated. And we know that particularly the expression of HER3 is dynamic and can be affected not only by HER2 inhibition, but actually just by chemoradiation in and of itself. And so in that context, the randomized phase 2 trial that came from the AIO group was very interesting to me. So this trial is called the Petrarca Trial. It's a randomized phase 2/3 trial. But as I mentioned, they've elected not to go forward with the phase 3 component. It was open to patients with clinical T2 to T4 esophagogastric adenocarcinoma, or NET, as long as it was nodal involvement. The patients all had to have HER2 expression, which was centrally assessed, and performance status up to 2 was allowed. And then patients were randomized to what has become the new standard of care, perioperative FLOT chemotherapy, or the same thing together with trastuzumab targeting HER2, as well as pertuzumab, which targets HER2's ability to heterodimerize with HER3. The trial was, the phase 2 portion was accrued, and then the JACOB trial, which was a trial that looked at that same strategy of trastuzumab plus pertuzumab in the metastatic recurrent setting, was reported out as having missed its primary endpoint. It's a publication from Tabernero et al. In Lancet Oncology in 2018. So in that trial, the control arm was chemotherapy with trastuzumab, the experimental arm was chemotherapy with trastuzumab and pertuzumab. Their target hazard ratio was 0.77, and they had sufficient power to detect a difference up to a hazard ratio of 0.836. And what happened was that the stratified hazard ratio for the trial was 0.84, and the p-value was 0.057. So although response rate went from 48% to 56.7%, PFS went from 7 to 8.5 months, and OS went from 14.2 to 17.5 months. The JACOB trial was formally negative, and that has, I think, put a spoke in the wheel of taking the Petrarca data forward to phase 3. But the Petrarca data were intriguing. The primary endpoint, if it was going to be reported just as a phase 2 trial, was pathologic complete response. And this was enhanced by the addition of pertuzumab. So it went from 12% to 35%. So it's nearly a tripling with a p-value of 0.02. And there was also a really intriguing downstaging, both of T-stage and nodal stage. So N0 was 39% with preoperative FLOT and 68% with preoperative FLOT plus trastuzumab plus pertuzumab. And then if you looked at those patients with advanced disease, so the T3, T4, that was 48% in the FLOT and 35% in the FLOT plus trastuzumab plus pertuzumab after therapy. There were also intriguing differences in disease-free survival and overall survival. For DFS, the median DFS for FLOT was 26 months. I think not off base at all for this group of patients. And with FLOT plus trastuzumab plus pertuzumab, that was not reached. The hazard ratio there is 0.576. And for overall survival, although it was not reached yet in either group, there does appear to be an advantage emerging for the use of trastuzumab plus pertuzumab with a hazard ratio there of 0.558. So I think the intriguing difference between these two trials, obviously the backbones are different. They're both small trials where there might be some heterogeneity between the arms. But I think that the real difference is the suggestion that adding pertuzumab and inhibiting the ability of HER2 to heterodimerize with HER3 in what's probably one of the predominant mechanisms of adaptive resistance to HER2-targeted therapy may actually be an extremely promising way to move forward for these patients. So I do hope that the Petrarca data eventually lead to a phase 3 trial, because I found these data extremely promising.